in some research, which we did to explore some key concepts, and then trying to make change through intervention work. So I'm going to start us off with some work related to developing theory. So this work began when I was a graduate student at the University of Connecticut. My primary advisor there was Dr. Diane Quinn, who studies concealable stigmatized identities, or stigmas like mental illness that you can't necessarily see just by looking at someone. I was in the social psychology division, and I also joined a pre-doctoral training program in the social processes of AIDS, which was led by Dr. Seth Kalichman in my second year. And the goal of the program was basically to take students who are receiving training in traditional areas of social psych, like stigma, and have them apply that to the context of HIV, so that they could kind of ultimately merge these two areas. And I loved it. That was like really the path for me. And just as some bonus content, thank you for coming today. Here is a picture of baby Valerie, Eileen, who I think is joining us. Hi, Eileen. And Laramie at Reading Terminal Market. I'll show you a bigger picture of that later so you can really dig in. But when I wasn't making Laramie and Eileen get into like these really substantial sandwiches, I was learning about stigma. And so our definition of stigma continues to evolve a little bit. So I'd like to take a look at a recent definition that came from Major and colleagues from the Oxford Handbook of Stigma, Discrimination, and Health. So Major and colleagues define stigma as a social construct. So social constructs are things that we create as a society. So gender norms is a good example of a social construct. This social construct is an expression of social power. Power is the backbone of stigma. It's what really creates and reinforces this phenomenon. And they note that stigma involves identifying a socially conferred mark that distinguishes individuals who bear this mark from others. Now, our marks can be identities, social categories or statuses, illnesses. There's a whole lot of different marks that fall into this stigma category. And then finally, they emphasize that stigma portrays them as deviating from normality and meriting devaluation. So basically, people with these marks are seen as different and deserving of poor treatment or discrimination. So key to this definition is that stigma is a social process. So it's like a sociological construct. And because stigma impacts individual people, social psychology for me was a great place to study it and to learn about it. So while I was at UConn, I learned about reasons why this social process might exist. So theorists have proposed that there are three fundamental functions of stigma, and these include to keep people down, away, or in. So keeping people down refers to exploitation and domination. So some groups in society have more power and resources than other groups, and stigma helps to perpetuate these power and resource differences. So racism in the United States is a great example of this type of stigma. And this is often what we're thinking about when we're thinking about oppression. Keeping people away refers to avoidance of disease. So theorists have argued that we've evolved processes to avoid people who may be infectious, even if they're not, who may harm our own health. So this would include HIV, Hansen's disease, tuberculosis, and others. And then keeping people in refers to the enforcement of social norms. So people who deviate from social norms are sometimes characterized as immoral. So LGBTQ stigma is an example of keeping people in, a sort of societal attempt to enforce people to stick to heterosexual and binary gender norms. And then drug use stigma is also an example of keeping people in, an attempt to stop people from using drugs. And while I was there, I started learning about intersectionality. Now, this is going to be an oversimplification. Laramie could give us an hour on intersectionality. But I will just note quickly that key populations and people living with HIV experience stigma due to a wide range of characteristics. So maybe their race, gender identity, class, HIV status, history of substance use, and other things. And so to really understand how stigma is experienced by individuals and how it affects people's outcomes, we really need to study these dimensions simultaneously and in an interactive way when we can. Importantly, intersectionality theory really calls our attention away from just the individual level experience of this and asks us to think about how all of these systems of oppression are interwoven, how all of these stigma processes together relate to each other, and also what we can do to disrupt and deconstruct those systems. Okay, so after UConn, I applied for postdocs, and I applied for postdocs in a wide variety of areas. In addition to what I'm sure was a very brilliant research statement, I ended up going down to Yale to work with Jeanette Ikovics. And in addition to what was a very brilliant research statement, I had met Jeanette when she came to give a talk, actually just like this, at the University of Connecticut. And Jeanette was head of this postdoctoral training program, a T32 program at the Center for Interdisciplinary Research on AIDS. And at UConn, there was encouragement for grad students to sign up for meetings with the speakers. And I totally didn't want to do that. I had no interest in meeting with anybody because that was very intimidating. Valerie Smith here said, Jeanette Ikovics is coming. You need to go meet with her. Laramie shepherded me into that meeting with Jeanette. We met with her. Jeanette was super gracious. She asked me she asked us both about our research. I was further along in in the program than Laramie, so she encouraged me to apply for the postdoc, which I eventually got. So big thanks to Laramie for this instrumental transition down the road there. So I worked with Jeanette, and Jack DeVideo was also at Yale, and I had met Jack when he was a faculty member at UConn, and Jack was in the psych department at Yale, so it's kind of straddling between, most of the time in public health, but then walking across campus to meet with Jack up in psychology. So Jack and I were invited to write a paper on stigma for a special issue on HIV for American Psychologists. And it was actually Seth who recommended us for the special issue, which was hugely generous and I think really speaks to the importance of having sponsors in your corner, those people who are going to say good things about you even when you're not in the room. For this paper, Jack and I in turn then went and invited Laura Bogart and David Williams to work with us to sort of flesh out a paper and a model of how stigma might relate to HIV disparities. So like a good model of stigma and health disparities, it starts with stigma and it ends with health disparities. Mm-hmm. And so we can think about HIV stigma, but all these other types of stigma as well, as we were talking about intersectionality. And we can think about disparities in risk, incidence and screening, treatment, and survival in the context of HIV. So our model then just gets a little bit more complicated. So first we can think about how this social process of stigma is manifested at the structural level or the level of society. So today we're going to talk a little bit when we get to Malaysia about laws that persecute LGBTQ folks. That's an example of structural stigma. These laws and others have a direct impact on health. So for example, someone who is arrested due to these laws is going to have health implications due to that arrest. Stigma is also manifested at the individual level among what social psychologists sometimes refer to as perceivers. These are people who don't necessarily live with the stigmatized characteristic themselves. In today's talk, we're going to talk a lot about doctors. So these can take the form of prejudice, stereotypes, and discrimination, which are affective, cognitive, and behavioral reactions to people who have a stigmatized status. And these can have a direct impact on health disparities as well. So for example, now apparently a doctor who is homophobic in Florida, right, doesn't have to provide care to an LGBTQ patient, it seems, or that law is on the way, I'm not totally sure. We've got avoidance coping going on here with structural stigma changes throughout the US, but so that can have a direct impact on people's health if they're denied care due to a stigmatized status. And then finally, stigma is manifested at the individual level among targets, among people who live with a stigmatized status themselves. These experiences are going to be shaped both by stigma that's in society, what their environment looks like, as well as how they're treated by other people. And then we've got a ton of research that links these experiences of stigma with HIV-related outcomes across the full continuum there. Okay, so in this grad school and postdoc phase of my career, I did a lot of thinking, a lot of trying to understand. I learned that stigma is a social process. It's inherently intersectional. It's manifested in our structures, in our interactions among individual people, and it undermines outcomes along the full, continuum of HIV prevention and care. I didn't cover it here, but I thought a lot about mediating mechanisms too, like how do people's experiences of stigma ultimately lead to these different types of health outcomes? How does it change their behaviors or how they feel? I also thought a lot about moderating factors like resilience. Okay, so let's get into some research. So while I was at Yale, I also connected with Jeff Wickersham. So Jeff has the beard here, and Jeff and I both went to UConn. So that's how we had known each other. Jeff was working with Rick Altice, and one of Rick's students, Harry Jin, was leading a project, like a summer research project on stigma in Malaysia. And Jeff called me in just to sort of pinch hit on how do you measure stigma, which is a question that comes up all the time. So I went in and made some recommendations on how to measure stigma while I was a postdoc at Yale, and then I continued working with them when I transitioned to Boston, where I worked at Boston Children's Hospital and Harvard Medical School. And I went there in part to work with Laura Bogart, who I had met by working on that American Psychologist paper together. So this is a talk about Malaysia and now Boston. So let's get back to Malaysia. A little bit of background for us. Malaysia is a Southeast Asian country on the Malay Peninsula and the island of Borneo. The capital is Kuala Lumpur. We have over 30 million people who live there. In terms of religion, the official religion is Islam, and 60% of the country or of the population does identify as Muslim, and 50% of the population identifies as Malay. And there's a lot of overlap between people who are Malay and people who are Muslim. In terms of HIV, there are about 82,000 people living with HIV in Malaysia. HIV has been historically concentrated among people who inject drugs, but over the last 10 years, we've seen an increase among men who have sex with men, or MSM, as well as transgender folks. And many people, latest estimate, 45% are not on antiretroviral therapy. Now, there are pronounced disparities in HIV testing and prevention efforts in Malaysia. So I'm going to look at or show you some data from UNAIDS, and we're going to look at the general population in this medium blue bars. Sex workers are going to be in gray, light blue is going to be MSM, like the darker blue is people who inject drugs, and then the gray on the side is going to be transgender folks. So, and what we can see here is that HIV prevalence currently is high among MSM. 21.6% of the population is estimated to be living with HIV, followed by 13.5% of folks who inject drugs, 11% among transgender folks, and 6% of sex workers. And this is compared to a prevalence of 0.3% overall. So really big HIV disparities here. In our next cluster of bars, we see HIV testing and status awareness. So we're seeing basically here that many members of our key population groups are not aware that they're living with HIV. So those rates range from 35% among sex workers up to 46% among men who have sex with men. And then in our final cluster of bars, we see coverage of HIV prevention programs, which is arguably too low considering the prevalence and the testing and status awareness numbers. So that ranges from 1.4% among people who inject drugs who are estimated to be receiving prevention programming, up to almost 60% among sex workers. But our MSM group, who we see are the highest, they're at 36%. So most are not receiving prevention counseling or prevention programs. So let's go back to our theoretical model, because when we see pronounced disparities like this, we know that stigma is a fundamental cause of disparities. So let's think a little bit about what the environment in Malaysia is related to stigma. Okay, so our model additionally theorizes, we talked about how the model theorizes that stigma is built into the structural level. So we've got structural stigma, and then that impacts people's experiences and HIV disparities. So let's take a moment to think about the structural environment itself. Now, this map highlights countries that have laws criminalizing consensual same-sex conduct throughout the world. These countries are in shades of red that have some variety of criminalization. There are 70 UN member states that do criminalize, 6 of which prescribe the death penalty. Here is Malaysia. It is red, and we're going to dig into that on the next slide. There are also legal barriers to freedom of expression and operation of civil society organizations to protect LGBTQ populations in Malaysia. Why is Malaysia red? So Malaysia has Penal Code Section 377, which I want to emphasize is a remnant of British colonial era law. You know, these are in many countries that used to be British colonies throughout the world. It states, whoever voluntarily commits carnal intercourse against the order of nature, which is defined as anal or oral penetration, shall be punished with imprisonment for a term which may extend to 20 years and shall also be liable to whipping. We also have Islamic Sharia law, which criminalizes anal sex among Muslims, with punishments including imprisonment, fines, and whipping. Malaysian religious officials regularly raid MSM venues such as bars, saunas, and parks to enforce Sharia law. Top Malaysian officials have publicly condemned MSM, and individuals continue to be imprisoned under these laws. Men persecuted under Section 377 describe physical and psychological abuse during their incarceration. Additionally, secular and Sharia laws criminalize the gender expression of transgender individuals, and Sharia law prohibits gender-affirming surgery among Muslims. Malaysia has harsh penalties for drug possession, including the death penalty. This is a big focus of reform currently for Malaysia, so hopefully we're going to see some changes. And sex work is criminalized. So sex workers even report being charged for sex-related crimes, related crimes on the basis of carrying condoms, which we can imagine is not great for our HIV prevention efforts. Okay, so we have this environment with pronounced stigma, which impacts our healthcare interactions. And our team was really curious about understanding the extent to which their future healthcare providers, their medical and dental students in this case, endorsed this stigma. So this project was a collaboration between colleagues at the University of Malaya and Yale University. And I'm going to share results from 3 different publications, and I'm going to kind of mix them together. So I hope you don't mind. So let's take a moment just to think about, why the team was focused on healthcare workers and students. I don't think I really need to convince anyone in this room, but this is what we were thinking. So we were focused on healthcare workers because they have the opportunity to facilitate these HIV prevention and treatment efforts, and also to address HIV and other health inequities that may affect key populations. We further focused on students in this group because they represent future healthcare workers, and also because students are trainable. We have the opportunity to implement potentially curriculum changes to address biases that may lead to inequities in care. Additionally, what I really love about this project is that the collaborators on the UM side are a group of really incredible infectious disease doctors who just see this as a problem and want to make some change. So that was another part of our motivation. So again, if we return to our theoretical model, here we're seeing that perceivers, such as doctors, can directly shape HIV-related outcomes and shape experiences of stigma among targets. So perceivers may endorse several different types of individual level stigma mechanisms. These include prejudice, which is negative emotions and feelings like anger. I sometimes say that prejudice lives in the heart. We also have stereotypes, which are group-based beliefs that are often applied to individuals, like a group of people are immoral. Sometimes they say that stereotypes like live in the head. And then we've got discrimination, which is poor treatment of individuals, such as an unwillingness to treat certain types of patients. So that's what people do. Sometimes with their hands, if we really want to carry this body thing out, but it's what people do. Okay, there's also though associative stigma, which is when people experience stigma from being with or working with a stigmatized group member. So healthcare workers, for example, may feel ashamed to work with patients living with HIV or patients who identify as LGBTQ. So we conducted a rather large survey of students it was all the way in 2012, which I have feelings about it being that long ago. But the survey went out to 7 Malaysian universities and targeted undergraduate medical and dental students who were pursuing a Bachelor of Medicine, Surgery, or Dental Surgery degrees. This was a cross-sectional online survey. It took about 30 minutes to complete, and it went out from university deans' offices. So we did have over we had 1,165 participants who completed the survey, which was terrific. They're about 22 years old on average. Mostly were female, almost 70%. And you can see that 62% identified as Malay, 64% identified as Muslim. And they were mostly clinical status, and 57% of them focused on dentistry, 42% were pursuing a medical degree. So we asked all participants how they felt towards patients in general, patients living with HIV, patients who have injected drugs, and patients who are men who have sex with men. And these scales ranged from 0, very negative, to 100, very positive. This was like my big contribution, right? Since I had been pulled in, I was like, put in some feelings thermometers. So feelings thermometers have been generally recommended to measure prejudice. So that's what we were trying to look at here. So what we see here in this first slide is that our participants felt pretty positively towards general patients, as they should, since they are, in training to work with them. So blue is overall, red is medical, and this like greenish is dental students. So medical students feel like a little more positively towards patients in general. They're feeling a little bit more ambivalence towards people living with HIV. We're getting closer to that 50% line. Again, medical students are a little bit more positive. And then here, we're starting to get more in the negative zone. So here, we're close to 40 towards people who inject drugs. No differences anymore between medical and dental students. And then MSM, we're close to 30. And no differences. And when I saw this, I mean, this is, 2012 in the US, we're headed towards marriage equality. We all should have expected this. I didn't expect this. I was really surprised to see this. You don't usually see such explicit negative feelings come out like when we use these scales in the US, for example. And then I'd also like to draw attention that we can see that Muslim students, who are in red here, had the most negative feelings towards MSM, scoring at a 24. And these other students were more in an ambivalent range. All right, in our next set of analyses, we took a look at how these feelings thermometers and other stigma-related constructs that we had collected were related to their intentions to discriminate against patients living with HIV. So we first looked at some correlations. We found that all of our feelings thermometers were related. So people who had more negative feelings towards one of those groups also had more negative feelings towards other groups. This was interesting to us for our later intervention work because it suggested maybe we need to intervene all at once. We also observed that almost all of these stigma-related variables were associated with their intentions to discriminate against patients living with HIV. We next conducted some regressions to further examine these associations with discrimination intentions. And so what we found was that women and dental students had greater intentions to discriminate, and participants with worse feelings towards people living with HIV, as measured by those feelings thermometers, those had more internalized shame about working with patients living with HIV. Those had more fear of HIV itself, and those who disagreed that people living with HIV deserve good care said that they were more likely to discriminate against patients living with HIV. So while we had this data set, we were also curious about whether we could learn anything to reduce stigma with these data. So contact theory was initially proposed by Allport, who was a contemporary of Goffman, who gave us some of our first definition of stigma. Allport held that prejudice towards outgroups, who are often people with stigmatized statuses, might be reduced through interpersonal contact, through interaction. And outgroups are just groups of people who are different in some way towards from the self, since he used that language. It has been proposed that contact leads to reduced prejudice through learning about outgroup members, people who are different from yourself, which leads to greater knowledge about those people, which can start busting our stereotypes, and also less anxiety or fear, which can kind of change our feelings or our prejudice. And ultimately, when prejudice is reduced, discrimination may also be reduced. So in healthcare settings, we would hope that reduced discrimination can mean improved health outcomes for our stigmatized group members. So we did ask our participants if they personally knew these different types of patients. So you can see here that very few students, ranging from 12 to 18%, said that they knew people living with HIV, people who inject drugs, 12 to 18%, and men who have sex with men. So not a lot. We also looked to see if these feelings differed, if students who had actually met people with these characteristics. So we did find that students felt more positively towards patients with histories of injection drug use and also MSM if they had met people from those groups before. So we were interested in looking at whether interactions with men who have sex with men had any associations with intentions to discriminate against that group once they became doctors. So based on the literature, we thought that these previous interactions, so having had contact, would be associated with lower stereotypes or less endorsement of stereotypes about that group and less fear of them. We thought that that in turn would be related to less prejudice and then less intentions to discriminate against MFM in healthcare settings. So we analyzed the results using path analysis. I have those tables if anyone wants to see them, but let's just look at this again. So what we found was support for this pathway. So we found that previous contact with men who have sex with men was associated with less fear, which in turn was associated with less prejudice and then lower intentions to discriminate. So basically we found that while this, for those of you who are, for Laramie doing her path analyses, this indirect effect was statistically significant and this one was not. And it sort of fell apart around stereotypes. Okay. So we just shared some findings that Malaysian medical and dental students endorse prejudice or negative feelings towards patients who are men who have sex with men in particular. They have more, also negative feelings towards patients who inject drugs, and they're a little bit more ambivalent towards patients living with HIV. We saw that prejudice towards patients living with HIV who are MSM and who have engaged in injection drug use in the past were all related to each other or correlated. And we found that intentions to discriminate against people living with HIV were related to prejudice, fear of HIV, and stigma associated with caring for someone who is living with HIV. And we saw that participants who had had contact with men who have sex with men had less fear, less prejudice towards, and less intentions to discriminate against MSM. All right, so we've covered theory. We've gotten into our social behavioral research that was guided by the theory, and now we're trying to do something about all of this. So this shift in my focus came along with another move from Boston Children's Hospital and Harvard Medical School down to Delaware. And while there are really terrific and amazing scholars at Delaware, because this is a career development talk, I'll share that a big part of our motivation was to live closer to family who live outside of Philadelphia and Harrisburg, as well as this me/dinosaur who lives here in Philly. Okay, so how did we start to make this transition from studying to intervening? In 2019, I took a sabbatical, which was awesome. And I went to Kuala Lumpur, the capital of Malaysia. I met with these colleagues who I've been working with at that point, I think for about 5 years. We went all over town. We visited lots of the community-based organizations and talked to them about what they were experiencing, what their needs were. Honestly, Laramie can probably tell you this, I would have been really happy just to run surveys and sit in my office and analyze results and write papers, but there was a real call to action around do anything to try to change this as a group, work together. So that is what we did. We baked the idea for an R34 award starting there, and then we wrote that together over the rest of 2019. We submitted that in January of 2020. Here's our team spanning University of Malaya, Delaware, Yale, and also Community Health Center in Connecticut. So we developed an idea for a stigma reduction intervention, which I will dive into in a few slides. So our goals for this R34 project were to conduct some preliminary work to inform the implementation of our intervention, and then to conduct our pilot. So pretty straightforward R34 aims. I'm just going to highlight one piece of aim 1, which is our photo voice study, because it's my favorite, and I hope you enjoy it. So I'm going to summarize results that were recently published in AIDS and Behavior. So this publication is out there if anyone wants to learn more about that. Our original plan was to do a traditional in-person photo voice. So we collaborated with John Cox, who is just like a phenomenal National Geographic explorer and a professor of photography at University of Delaware. We were going to fly John out to Malaysia. He was going to lead like a very moving, a very effective in-person photo voice experience. We were all very excited. Then we got these plans that we made in 2019 and applied for in January of 2020. We got funding for them we heard that we did well in May of 2020. I called Laramie immediately. I think Nexus was coming, or was it Nexus was also in that round. So that was fun. And then we got funding in July, and then we were supposed to do this really fantastic photo voice study in fall of 2020, which was not going to happen. So we switched gears, we made some lemonade, and we tried out online asynchronous photo voice methods. We built a website to facilitate this photo voice project. So it included a series of videos from the doctors on our team, kind of explaining why they wanted to learn things from key populations and folks living with HIV about their experiences, as well as from John, who taught people about photography. And honestly, it went even better than we could have hoped in many ways. We worked with our community partners to recruit our participants from key population groups and folks living with HIV. Half of our participants used the English version of the website, and half of them used the Bahasa Malay version of the website. And in case anyone is interested, because we spent a lot of time figuring this out, we published a paper on our methods alongside our other Stigma photo voice paper in AIDS and Behavior. So those are kind of out there as a pair. Okay, so we have a series of prompts that participants responded to. For this paper, we analyzed data in response to 2 of the prompts specifically. So the first one was, how do doctors see you? So a few participants did note positive experiences. So I'm going to include those. Examples of those were that the doctors want the best for their patients, including them, but many of them did describe stigmatizing experiences, such as being misgendered, being seen as small, misguided, and incapable, their words. And interestingly, we had a theme of a handful of participants saying that they responded to these stigmatizing experiences by wearing a mask in healthcare settings, which I found to be really interesting. So here's an example of a positive experiences. This is from a female sex worker who said, even though I'm a sex worker, the doctor I visit still treats me like other human beings, even though I do activities that are outside of the norms of other human beings. The doctor feels that I should be treated like other human beings. Here's a stigmatizing experience, a man who has sex with men, who said, I feel like doctors see me as not normal, or one may call it a freak. Ever went to a clinic to get myself tested, HIV tested, so I can know my status. The doctors were shook and looked at me weirdly. Oh, great, for HIV testing. This is in response to a different question, what makes you feel sad? But it gives you a sense of some of these responses around participants saying that they wear masks. This participant, who was also a man who has sex with men, said, the mask that I have to wear when I approach new people or forced to wear by society. People expect me to wear a certain mask to blend in with the norm. It saddens me that I have to hide who I am, even though I have been through a lot to take it off. Now, despite these stigmatizing experiences that came through, the participants expressed a good deal of hope for their future interactions with doctors, which was really interesting. They wanted doctors to see their value, that they are intelligent, capable, and bright. They wanted to receive non-stigmatizing treatment, to be seen as individuals. And they talked about wanting to take off these masks to be supported and protected by their doctors so that they could be healthy. So here's an example from a transgender woman who said, I just hope the doctors treat me as a woman and equally with other patients without any stigma or discrimination. I just want to be healthy and peaceful like the nature in the picture. This participant, who is a patient living with HIV, said, I want the doctor to know about me that I am strong, but there are times when I get scared when I face the limitation of this disease where I need the support of medical knowledge in terms of facts and moral support. And this is our team favorite. A man who has sex with men who says, I want doctors to know that I want to be free of being myself around them, to spread my wings and share my experiences with them so they can help me reach the skies. But at the end of the day, I'm still human. My wings may need tending when I make a mistake. And I know I have good doctors that I can trust that can treat me without clipping my wings in the process. So our photo voice study was done to both better understand the lived experiences of key populations and people living with HIV in healthcare settings, and to create content to be used for our intervention. So we created videos from these photos that were shown to participants in the stigma reduction condition of our intervention. We also did a lot of community engagement to share these photos, which I'd be happy to talk about if folks were interested in how we've done that and how we're continuing to do that. Well, let's take a look at what this intervention looked like. Before we get too excited, I have to tell you that we finished delivering the intervention at the end of March. We collected data through April, and here I am to tell you about an intervention that we haven't analyzed the results for. So it's going to be disappointing because we just, I just cleaned the data last week and sent it to our statistician. So, Laramie and I had talked about that. And so I'm here to warn you that this is like a true career development talk because things are still developing, but I'd like to share with you the idea that we tested. So by way of just a little bit of background, we do, I think at this point, have a sense of tools that can reduce stigma or intervention activities that we can engage in. So we have quite a few now reviews of the intervention literature. They suggest that things like education and clinical skills, facilitating contact, trying to shape social norms, and even behavioral design, which I'm happy to talk more about, can help to reduce stigma. And specifically to reduce stereotypes, prejudice, and discrimination among this perceiver group or among potentially our doctors. In addition to identifying stigma intervention tools, previous research has suggested some ways in which we should be using our tools to make sure that they are effective. So in particular, they should be longitudinal. The research suggests that single session interventions don't necessarily lead to lasting change, especially among our perceivers. They should be multi-level. So stigma change at one level is not necessarily going to be sustained unless we're also trying to change it at other levels, like the individual level and the structural or the interpersonal level. And there should be multi-component, or they should be multi-component. So the research suggests that, using one stigma reduction change in isolation, like just knowledge only, may not be as powerful as combining it with something else, like building clinical skills, for example. So after developing a sense of the tools that we wanted to use and how we wanted to use them, we looked for a vehicle to essentially deliver them. And we landed on Project Echo for this project. So Project Echo is designed to train and support clinicians to deliver specialty services. These programs usually last for several months, which is great if you want to be delivering your stigma intervention tools longitudinally. It uses a hub and spoke model, wherein non-specialists in community settings, which are the spokes, meet with and learn from specialists who are often in academic hubs. And these are the hub and spoke model. This is our hub, so our subject matter experts. The non-specialists develop expertise in the specialty area, and then they are the ones who provide care directly to their patients. So importantly, it's not a telemedicine program where the subject matter or the experts or the specialists are directly treating patients. It's a model in which the experts are working with clinicians who are generalists, teaching them how to do things, and then they are providing the care to their own patients in their own communities. So in our intervention, our ECHO participants were family medicine and primary care doctors, and our subject matter experts were from the University of Malaya, as well as other folks that our team had worked with over the years. So for this project, we recruited 78 general practitioner and family medicine clinicians. We randomized them to 3 different conditions. This included a Project ECHO for HIV prevention and stigma reduction. So we put all of our stigma reduction tools into one of our Project ECHOs, a Project ECHO for HIV prevention only. So this looks a lot like lots of other Project ECHOs for HIV prevention that are happen all over the world. And then we had an HIV Connect condition. HIV Connect is an asynchronous webinar that Malaysian doctors can already take for continuing education to learn about HIV prevention. So we included this as sort of a standard of care in this trial. So let's just take a moment to compare these 3 conditions a little bit further. So HIV Connect was delivered online and asynchronously once per month. So we sent our participants basically like a video to watch once per month. The Project ECHOs, both of them, they met twice per month, every other week, synchronously online. So these were essentially Zoom meetings, which we are all very familiar by now. The faculty expertise differed across the 3 conditions. So HIV Connect was led by infectious disease doctors. Our Project ECHO for HIV prevention added family medicine and mental health experts. And then our stigma reduction condition added stigma, like a stigma expert from the University of Malaya, as well as a community representative from one of the local CBOs. In terms of content, HIV Connect is a didactic, so it's a asynchronous webinar. Traditionally, Project ECHOs consist of a very brief didactic, maybe 15 minutes, and then a case presentation and lots of engagement and discussion. So that's what the traditional Project ECHO looked like. And then in our stigma reduction condition, we added those photo voice presentations, the videos that we made from the participants who engaged in that part of the study. And then we had a bunch of guest speakers come in from Malaysia. So folks who worked at local community-based organizations, folks who were members of key population groups. We had a lot of people filter through that group. Now, for me, the tricky part about this project is that many things in medical education might theoretically reduce stigma, given that education itself is a stigma reduction tool. So all of our conditions theoretically have some sort of stigma reduction tool in them. Here we have education and building clinical skills. In Project ECHO, we have education, clinical skills, and then we thought maybe we're going to get some social norming happening in here, especially because we're going to have infectious disease doctors and mental health folks in here who might be modeling like low stigma for the group. And then finally, in our Project ECHO for HIV prevention and stigma reduction, education looked a little bit different than our other Project ECHO because we had a lot more content focusing on key population groups as well as specific modules on stigma. We also had contact, which the other conditions didn't have. So we had that photo voice again. Guest speakers and members of our hub faculty were also from key population groups. Okay, our team did a lot to encourage retention and participation in the trainings because by the time we initiated the study in July of 2022, and by that time things related to COVID had settled down, but now we have Mpox. So it was we did a lot to try to get people to show up for these sessions. So across the board for participants in all of our conditions, we sent them emails, we sent them WhatsApp messages, and we gave them lunch vouchers for coming. And the lunch vouchers is done in other ECHO sessions as well. So we started running the program in July of 2022, which I just noted, and we just ended at the end of March. So this was a 9-month-long program. And starting at the beginning line, which I'm sure all of you can relate to, our big question is like, is anybody going to come to any of this? So we found that people did come. So actually in our HIV Connect group, which is this blue line at the top, people really came. So everybody but 2 people did all of the sessions in the HIV Connect group. So I think what we learned here is that if you incentivize asynchronous webinars and send lots of reminders to do them, people may just go ahead and do them. So that was kind of interesting. Our Project Echo groups also mostly tuned in. So what you can see here is that attendance started a little bit higher, came down just a bit over time, which we expected. And then we had a few noticeable dips around, there was a scheduling conflict with a conference early on that we realized, oh, we need to pay more attention to that. And then around, I think that's week like 14 or 15, that was all of the holidays. And we were also bumping up against Chinese New Year there. So we had another dip before we came back up at the end of the year. So the purple line was our stigma reduction echo, and the yellow line was the standard echo. So they were pretty much the same in terms of attendance.
Yeah. How did you incentivize the HIV Connect participation?
So they got the same incentives as the others as well. So they also got a lunch voucher. So if we saw that they did it, they got the lunch voucher. It was a little bit strange because then they get the lunch voucher after they've done it, but people use those and like them. Does that answer your question?
Yes.
Okay, great. Okay, so our main finding is that people came, maybe because of the lunch vouchers and all of the reminders. It's a pilot study, so we were happy that we were able to recruit our participants. We were able to randomize them. We sent them many, many reminders and they showed up. So we were pleased with that. They also responded to our surveys. So we surveyed them at baseline, halfway through, and at the end. 76 out of 78 of our participants responded to that final survey. So pretty good. And that is the data that we are currently digging into. I'm sorry that I don't have it here to share with you today. So thank you so much. Yes, anytime. I would love to. Okay, so now we're caught up like to real time because I sent that as data to my statistician last week. So I'll stop here in case there are other questions. Before I do, I'd like to offer up a big thank you to NIMH. This is I'm so sorry I don't have like the data to share with you, apology photo. So hopefully that helps to smooth things over a little bit. And I'd also like to acknowledge our super phenomenal team that you saw on the slides earlier, especially the folks over at who did all of the work to keep people involved in the study. So they're just phenomenal. I'm really lucky for the opportunity to work with them. So I know we don't have a ton of time. I'm sorry. I got a little overly ambitious, but if anyone has questions, I'd be happy to answer them.